Surge. And at this time, let us remember our lost loved ones, colleagues, friends, countrymen. May they rest in peace. This morning, before we get started with our guest speaker, we will have Ms. Gia Ferguson from Psychiatrists joining us to share with us some very exciting news about their non-communicable diseases app. So, Ms. Ferguson, you can take it away.
Good morning, everyone. Can you see my screen?
Yes, we can.
Okay, good morning. My name is Giovanna Ferguson, a medical representative with Lowe's Pharmaceuticals, and my brand is Beatrice. Today, I wanted to present to you all the Entity Academy, which is a first of its kind collaboration between global partners in introducing healthcare and e-learning. The global partners would be the World Heart Federation, the Entity Alliance, and we are the founding sponsors. So what the Entity Academy is an app-based program that is optimized for the mobile phone with a desktop version that's also available to you. It's available for free worldwide with lessons that can be downloaded and complete later offline at your own pace. The e-learning lessons that emulate the experience of traditional training through interactive explanation of guidelines and practice in the form of knowledge check question, trivia, and other games. We have courses that span the big five, the entities that contribute most to global mortality and morbidity, which would be cardiovascular disease, cancer, chronic respiratory diseases, diabetes, as well as mental health. So the course is accredited. It is accredited by the American College of Cardiology, and upon completion of each module, the ACP will be able to download the certificate for upload and submit it to the Medical Council. What we're trying to do is eliminate the barriers to access for the program. We have live programs that tend to target physicians in certain countries or regions, and it only favors the ACPs who are available at that predetermined time. And it may not work for everyone's schedules. You may have an emergency coming up, you may have to stop watching the Zoom. It's very hard sometimes to keep active and pay attention during the call. So the Entity Academy is allowing you to learn on the go. The inaugural course was released last year, July 2020, and it's on cardiovascular disease and stroke prevention, which are the essentials for primary care. We also have a mini course on COVID-19, protecting patients at greatest risk. It's on COVID-19 basics, evaluation and basic treatment, antiviral therapies, cardiovascular complications, and broader NTD considerations. The app is available on Google Play as well as the App Store, so you can get it available on both your Android and iPhone devices, and this is also a link for the online version, ntdacademy.acc.org. Also want to remind you that we have Zoloft 50 and 100 milligrams available for you for your patients with major depressive disorder, OCD, PTSD, social anxiety disorder, premenstrual dysphoric disorder as well, and panic disorder. And we additionally have Caduet that is now available in the market, the best of two molecules in one for amlodipine and atorvastatin. This will be for your patients with hypertension and obesity, cardiovascular disease, metabolic syndrome, diabetes, dyslipidemia, as well as your hypertensive patients with stress. This is a short video explaining the NTD. Thank you so much for your attention. Any questions, please see my information in the chat. Thank you.
Thank you very much, Ms. Gia Ferguson from Viatris, for sharing that video with us. And what we will do is we will share the information outside of the meeting so that everyone has access to it, because it's a great way to obtain additional CMEs that are accredited at no cost to us. So thank you very, very much, Ms. Ferguson and Beatrice. So on to our meeting, and thank you to everyone for joining us. In our daily practice, we all come across a patient that we are concerned might be addicted to pain medications. So it is with excitement to hear this presentation from Dr. Adina Bowe, who is the Assistant Professor in Internal Medicine and Psychiatry. She's the Medical Director of Comprehensive Opioid Addiction Treatment, and she works at the West Virginia University Charleston Area Medical Center, and she has been holding this position since 2018. So Dr. Bowe is no stranger to most of you, as after completing her undergraduate education in 2000, she finished her MBBS at the University of the West Indies, Jamaica, did her internship at Princess Margaret Hospital and Durand Memorial Hospital, and finished off as Intern of the Year that year in 2005 at the Durand Memorial Hospital, after which she became a senior house officer in Grand Bahama in the Department of Psychiatry. In 2008, she went off and did her internal medicine and psychiatry residency in the Charleston area at the West Virginia University. And then in 2013, she did a fellowship in addiction psychiatry at Yale University in Connecticut. She is board certified in internal medicine, psychiatry and neurology, addiction psychiatry, preventive medicine, and she holds memberships with the Academy of Addiction Psychiatry, the American Psychiatric Association, the American Medical Association. She's a Gold Humanism Honor Society awardee. She's a past member of the Grand Bahama Medical and Dental Association and a past member of the Junior Doctors Association of the Bahamas. In 2005, she received the Dr. Aubrey McFarlane Bursary Surgical Prize, and she holds many advisory positions. Presently, in the Charleston area, she's on the board of directors of the Opioid Task Force. At Yale University, she serves on the board of directors for REACH, recognizing and eliminating disparities in addiction through culturally informed healthcare. And she's also on the board of directors of the American Academy of Addiction Psychiatry. She's the chairperson for diversity and inclusiveness. She's very involved in volunteering and has done so with REACH at Yale University, conducting free clinics for treating patients with medical illnesses and psychiatric disorders in the West Virginia healthcare system at West Virginia University, where she's the clinical assistant professor. She has participated in teaching an addiction medicine course to medical students, residents, attendings, and psychologists, in addition to other undergraduate teaching and volunteering with youth groups. Here at home, as most of you may remember, in Grand Bahama, when she was a member of the Dental Association, she was the Grand Bahama Dental and Medical Association. She was a member of the psychiatric team that went into the high schools and educated adolescents about mental illness. She has 6 publications in peer-reviewed journals, some of them being Neuropsychiatric Impairment in Septic Shock Survivor, New Onset Psychosis, Consider Epilepsy, and the Approach to Pain Management in a Large Outpatient Clinic Population. She has participated in many workshop presentations and numerous meetings, the most recent of them being participation at the American Psychiatric Association meeting in 2020, her topic being Integrating Addiction Treatment into Primary Care, Opportunities for Psychiatrists. In September of 2020, she did an oral presentation with Dr. Bartlett in Grand Bahama in How to Prepare for a Crisis, Coping with COVID, a She was a virtual panel guest speaker for the Ministry of Education and Grand Bahama Principals and Vice Principals Association. The program was entitled Transitioning to the New Normal, a Healthier You and a Healthier Community. Her hobbies and interests: sailing, running, going to the gym, hiking and kayaking, and working on her peer reviews for the Journal of Dual Diagnosis and the Journal of Psychoactive Drugs. Some of her other awards and accomplishments: Woman in Medicine Top Internist 2020, Outstanding Teacher in Behavioral Medicine and Psychiatry 2019, Program of the Year Apogee Hospital Hospitalist 2017, Outstanding Resident Student Educator Award for Psychiatry in 2011. With this admirable teaching, research, and awards background, today's speaker will enlighten us on addiction to pain medicine. Welcome, 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 Dr. Adina Bowe.
Good morning. It's great to be here. Thank you so much for the invitation. What I'm going to try to do now is share my screen. And I think I am screen sharing. Can you all see it?
Yeah. Yes, we can.
Okay. So I am so happy to be here amongst my people. Thank you for all the participants who made it out this morning. And I got to let you know, when I do presentations, I like it to be kind of interactive. So I'm going to beg Dr. Black to help me a bit, because as I ask questions to the audience, I would love it if you all put your answers in the chat and she kind of tell me what you all are thinking, okay? So today's topic is, I'm worried, is my patient addicted to pain medications or not? I want to say, of course, I have no conflicts of interest and no disclosures. Today, we have 3 objectives. Number 1, for physicians to be more comfortable in assessing their patients for an opioid use disorder, and that's what we call addiction to opioids. For number 2, for physicians to become more competent at performing a risk assessment to recognize at-risk behaviors for opioid use disorder. And finally, for physicians to be more knowledgeable in formulating a treatment plan based on risk assessment for opioid use disorder. And how we're going to do this, we're going to go through a case scenario, addiction criteria and clues, another case scenario. We're going to talk about performing a risk assessment and then devising a treatment plan. So I want you all to think about the cases as I present them. And the question is, addicted or not? And I want you to think about your patient in these 4 different categories. Do they have chronic pain that is well controlled? Do they have inadequately treated pain? Are they a treatment non-responder? Oh man, do they have addiction? This is the first case. You have a 33-year-old male with sickle cell disease who comes to walk-in clinic with pain in his left ankle. He had an ankle sprain 2 weeks ago and had obtained tramadol 50 milligram tablets from the emergency department, and he ran out and requested more. He says Motrin, ibuprofen, Nsaids, they don't work. However, the physical exam is not consistent with an ankle sprain. Also, he has what you see bug bites on his arms. He's staggering. He smells alcohol in his breath, and his eyes are really red, okay? So first of all, I got to point out a cultural difference. When we see patients like this in America, they're usually Caucasian, and the bug bites you can see on their arms. Does anyone have any idea what I'm trying to portray with these bug bites? You can just put it in the chat.
So I'll give them a couple seconds to put their answer in the chat. I haven't seen anything pop up in the chat as yet.
I'll go on, okay? And you let me know if anyone thinks of anything.
I will. Please don't be shy, audience.
Yeah, there's no right or wrong answers to my question, simply because when it comes to pain treatment, it is mostly best practices, right? There's no clear-cut evidence-based management. So just kind of want you to know that you won't be shamed, or no one's going to look at you and think, oh, you don't know that. All right, just give me what you all think should be the answer. So for this
we have 2 IV drug use.
Yeah, that's exactly what it is. Now, that's not big in the Bahamas, but over here in the States, it's huge. And when you look at someone's arms, you can look between the fingernails, you can look at underneath the breast. If it's a woman, you can see the track marks. Good job. So question for the audience, would you give this patient narcotics or not?
Okay, so far we have someone saying track marks, which is consistent with the previous question, and we also have no.
Okay,
And I
no.
will answer no.
Right. And I agree with you all. The answer for this patient is more likely no, because when you look at and evaluate this patient, he's already gotten pain medications, and he also has other issues going on. The injected eyes can clue you into being high with marijuana. He's staggering, his alcohol in his breath, but most importantly, his physical exam is not consistent with what he's saying. Okay, so let's go to the next case, because of course, it's not always that easy. You have a 55-year-old Black male. He complains of worsening pain in both hips for the past 10 years. His history, physical exam, and X-ray films are consistent with severe avascular necrosis of the femoral heads from sickle cell disease. He has been compliant with their recommendations. He has done physical therapy, heat and cool compresses. He's used the Nsaids. He's also used tramadol. He tells you, hey, doc, the Nsaids and the tramadol no longer provide relief, and he would like some oxycodone. He has a past history of cocaine dependence. Clinical decision time for my audience, okay? What are you gonna do? You're gonna give him some oxycodone, or are you gonna tell him, no boss, you continue with Nsaids and tramadol, or are you gonna say, pass this to orthopedics, refer to orthopedics for a second opinion? What are most people thinking?
Okay, so I am seeing, what was B? B was the answer. B, ortho, C.
Yes, and you see, for this case, it's pretty difficult, right? In your opinion, where is your patient? Does this patient have chronic pain that's well controlled? Does this patient have inadequately treated pain? Is this patient a treatment non-responder, or does he have issues with addiction? And actually, for this gentleman, what he had was inadequately treated pain, okay? So he has a history of avascular necrosis, and for those of us who have patients like that, that's incredibly painful. And over time, it gets worse with all that wear and tear on your joints. He has done what we said. He's done the tramadol, he's done the Nsaids, he's done the physical therapy. And so even though he has a history of cocaine use disorder, it is perfectly appropriate to actually escalate his therapy, okay? Sometimes before my training, however, I felt so scared giving these people more oxycodone. I'd be like, man, he on tramadol, and according to the books, it should be working, and I want, make this thing worse, and he come in here every second for this pain medicine. But in some cases, chronic pain does get worse over time, and we do have to escalate our therapy. So let's talk a little. Oh, go ahead.
So we do have an answer. Give the oxycodone and refer to ortho.
Yeah, that is the ideal case. Good job. All right, cooking with gas. So let's talk a little bit about addiction. Addiction is a neurobiological disease. It has genetic, psychosocial, and environmental factors, okay? And it's characterized by several behaviors. When I say genetic, what you should know is that 40 to 60% of people with addiction disorders, we call it substance use disorders, there's a genetic component. They either have family members, uncles, aunts, fathers, mothers, who also have the same issue. When we talk about psychosocial, we're talking about the emotional component as well as where they are socioeconomically. Because you would find lots of people with substance use disorders, they have issues with depression, anxiety, panic attacks. They may also have comorbids, other substance use disorders such as alcohol use disorder, nicotine dependence, in addition to opioid use disorder. When we talk about our environmental factors, we're talking about the situation they live in, okay? Are you under chronic stress? And what's going on in the home environment? And when we talk about addiction, when I put on my internal medicine hat, I think about it in 3 terms, because basically the psychiatric terms we use is so much, you don't think about it when you're an internist. So for our internists on the line, we think about compulsion, control, consequences. For my psychiatrists, if any of them on the line, we have our DSM-5 criteria. When you have your patient in front of you and you are trying to figure out, is this patient addicted to this medicine, or do they have dependence on, or just a physical dependence? You got to think about these things. Is there poor control over drug use? Are they using their medications before they're supposed to be due? So you give a month worth and in 2 weeks it's out. But not only that, is it compulsive? Are they able to control themselves over it? Or do they have to go and get it? Are they still using this despite their family members telling you, man, put that down, man, you're ruining your life, okay? Or are they still using it and making depression worse? Are they still using it and like driving, using their pain medicines, drinking alcohol and hopping in the car and driving? Do they have medical problems associated with it, like infective endocarditis? Or if it's alcohol, substance use disorder, do they have liver disease, okay? Is there a craving for the drug? Do they go to sleep thinking about it? Do they wake up thinking about it? Do they have drug dreams? And this occurs over a 12-month course. So a part of the substance use disorder criteria is something called tolerance and withdrawal. We just call that substance use disorder, but that's not necessarily addiction, okay? So for example, let me give you a case scenario what actually happened over here. So this 44-year-old female, she came into the emergency department. I was an internist on, and so I work a lot of nights back in Virginia. She came and she was like, doc, I ordered my pain medicine. My back hurting me. I need some pain medicine. She was referred to the emergency department. So the emergency department doctor looked at her and said, well, you out of medicine. I'm not your usual prescriber. Clinically, you have no reason for me to get this. She hopped in a car, jumped out, ran and crashed a car and came back into ambulance. When the emergency room doctor looked at her, she was like, now you can give me my pain medicine. I in a car accident. That's addiction, okay? So I have a question for you all. True or false? If a patient demonstrates withdrawal symptoms, that means they're addicted to the drug. Put it in your chat, please.
False.
That's right. That is false, okay? So if you give a patient opioids, say that how many of us on this line, there are like maybe 100 people on this call. Say your doctors gave all of us oxycodone or meperidine or tramadol. 30 of us are going to have problems with withdrawal after we've been on it chronically, okay? So not everyone develops withdrawal, but statistics show at least 30% of people on chronic opioid therapy will have withdrawal. Does not mean they're addicted. True or false? If a patient keeps asking for higher doses of pain medications, that means they're drug seeking.
So we're waiting for an answer to pop up in the chat.
I'm gonna pause right there and wait.
We have a true and we have a false.
Yes, see, because we all think this way, right? And
yes.
And just based on this, which is what I've given you, there's no way to tell. But what you should know, oh, go ahead.
Now we have like maybe 7 falses again.
Okay, that's excellent. So it does not necessarily mean you are drug seeking, okay? Just because you keep asking for higher doses of pain medications, because guess what? Over time, they stop working. So these things are often confused with addiction, physical dependence, and tolerance. So our clients, at least 30 to 40% of them over time on chronic opioids are going to become physically dependent, and they're going to have tolerance. They're going to come to you every 3-4 months. Man, this medicine ain't working, man. You need to do something for me. Increase my medicine, okay? And then as providers, we get so frustrated because we're thinking, why every time I see you now, I have to go up in this pain medicine? What you doing with these medicine, And it can be scary because you're not sure if this patient actually has pain or they have a problem with the medicine. Physical dependence also can make us confused, especially if our patients are in the hospital and we're seeing them go through withdrawal. Signs of opiate withdrawal are the yawning, okay? The sweating, and you have blood pressure going up, going down. You can have the eyes very dilated. And then our patients who are in withdrawal, they often have severe body pains all over. And that's actually a clue. If you ask the patient, where does it hurt? They go, man, everywhere, man. That's withdrawal and dependence, okay? However, if they have an acute injury, like broken wrist, and they said, right here, doc, that's not withdrawal. Does that make sense? I hope so.
Yeah. Yes. So Dr. Bowe, before you leave that question, there were some comments. Depends on the clinical scenario. Mm-hmm. I agree. Depends on clinical scenario and habits of the patient. Mm-hmm. What is the physiology for this type of problem? Is genetics involved?
Okay. Yes. In terms of physiology, the genetics are involved, and it has to do a lot with receptors, okay? Especially when it comes to tolerance. So I think everyone here is aware of the CYP450 in the liver, right? That how medications are metabolized. So when it comes to opioids, you have people who have the normal genes, you have people who are slow metabolizers and people who are fast metabolizers. And that's just through the 2D6. Some people have abnormal 2D6. And this is why they either have no response to opioids or they have minimal response to opioids. Some people, though, are slow metabolizers. You give them maybe 25 or 50 of tramadol, one pill, they're good for a whole 2-3 days, okay? So it's a lot to do with genetics. That's a good question. Pseudo addiction, right? Is often confused with addiction. That's our clients who are in the hospital, and every 2 hours, if their pain medicine is due, then they're hitting that call button, calling the nurse, all right? And of course, the nurse is getting more and more frustrated. So asking for pain medicine on time or a couple of minutes before time should not be confused with addiction. Let's talk a little bit about making the assessment. This is your last case scenario. You have a 32-year-old Black female with HPSC. She has chronic back, knees, and hip pain. She is in opioid withdrawal in the examination room, which means she's yawning, she's sweating, she's goosebumps all up, blood pressure all the way up in the 180s, diastolics in the hundreds. All right, she's having nausea, vomiting, diarrhea just coming out. Her review of her records show that she goes to the emergency department a lot. You all did a urine drug screen on her, and it shows she has benzodiazepines on it. Her home medication is oxycodone, 10 milligrams every 4 hours, and she ran out 3 days ago, which is 2 weeks before her next script is due. And she's asking you all for pain medications. What are you going to do? How would you approach this patient? So before we go on, let's talk a little bit about pain syndromes, and we're just going to talk a little bit about it in sickle cell disease. When we talk about pain in sickle cell disease, we kind of think about it in 3 different categories. You have the vaso-occlusive pain, you have central sensitization, and you have cyclical opioid withdrawal. And in terms of the last 2, you can think about those 2 and anyone on chronic opioid therapy. So our vaso-occlusive, you just have recurrent episodes of hypoxic ischemic injury to bones and tissues due to vaso-occlusion. This results in inflammation and tissue damage that leads to repetitive nociceptive injury. When we talk about central sensitization, we see this term a lot with chronic pain, okay? You have this phenomenon called hyperalgesia, which means things that should not usually cause 5 out of 10 pain is causing 10 out of 10 pain. So if I stub my toe, I should have a pain maybe 5 out of 10. But when I'm a chronic pain person, because of central sensitization, I feel it's 10 out of 10. You as a provider looking at me saying, she talking about now, man. It can't be hurting that much. But it is, especially people in chronic opioid therapy. You have this other concept called Oladinia, okay? That's when you have perceptions that should not cause pain, that is causing pain. Like if I touch ice, or if a blade of grass touch me, or if maybe I touch some heat, my body experiences that as pain. We're all familiar with neuropathic pain, okay? And then you have this concept called opioid-induced hyperalgesia. And what that means is persons who are on chronic opioids, over time, their pain gets worse because of the opioid. And actually, when you wean them down, their pain gets better, okay? Of course, it's very difficult to wean patients down off pain medications because they're already fixed to their medicine and think this is the only thing that can help them. So when you think about chronic pain, keep in mind these 4 things. Finally, you have cyclical opioid withdrawal. And boy, I see this all the time. This is a self-perpetuating cycle of pain, exacerbation, and opiate withdrawal that's triggered by abrupt cessation or tapering off chronic long-term use or high doses. And is often under-recognized by providers and patients. So these are the people who will present to your clinic or to the emergency department in severe pain. And it's because their opioids have stopped. So the patients who run out early, right? She comes in severe pain because she has cyclical opioid withdrawal. Or you might have someone who has chronic pancreatitis. They're on tramadol all the time. However, their doctor has just weaned them off of 400 daily down to like 75 daily. They go into an opioid withdrawal. It is scary to look at. Sometimes these people are screaming, crying on the bed. A lot of times they threaten suicide unless you give them their pain medications. When we talk about prescribing opioids, we have to look at it in a responsible manner, okay? When we prescribe opioids, it should be prescribed on a trial basis to be continued only if there's progression towards functional goals that is demonstrated. And that means that, so your patient comes to you and says, man, Nsaids ain't working, tramadol is an opioid, but tramadol is not working, I need something a little higher. And you go, well, let me increase the dose of tramadol, or let me increase and give you some oxycodone. However, they should have a goal to it. It should be like, so what you want this medicine for? Well, I need to be able to interact with my grandkids, or I'm on the basketball team, I need to be able to play basketball. That should be something demonstrable that is improving, okay? As physicians, clinicians, we should be having ongoing monitoring for safety and effectiveness. And if we suspect ineffective, unsafe, or diverted opioids, they should be promptly tapered or stopped. It is very important to know the opioid potency, all right? Because what I've seen happen sometimes is someone who's on maybe oxycodone, a physician change them to meperidine, or pethidine, or tramadol, thinking that, oh, I just need to change to opioid. It is important for us to know our morphine equivalence. Okay, so for example, we can see meperidine is 10 times less potent than morphine, whereas oxycodone is 1.5 times more potent than morphine. And we see methadone, depending on the dose, is at least 3 times and even up to 10 times more potent than morphine. And it's so important to know, because what you don't want to do is underdose or overdose your patient. Question back for the audience. What percentage of people who are placed on high-dose opioids will become dependent on them, physical dependence? I kind of mentioned it earlier. Is it 1/6? Is it 1/3? Or is it 3/4?
So we have an answer, 1/3, B.
Yes, very good. Okay.
So a couple more Bs. And before you actually got to cyclical pain, that was mentioned, and the question was asked, what do you do if they threaten suicide?
Okay, so if they threaten suicide, I take it very seriously. I do a risk assessment. If they are actively suicidal, I actually admit them to the psychiatric ward. I would not give opioids at a higher dose unless medically necessary, okay? So, or I can offer them, taper them off their opioids. But always, as a psychiatrist, I always take anyone, they say suicide very seriously because their pain is that bad. Most people don't roll up to your office or roll up to ER saying, I can kill myself, you don't give me this thing. So people who are like that, they're in significant distress. I would not tell them, bye, go home then. I've seen that done actually. Someone tell a patient, you're in suicide, you're saying this because you're trying to get my pain medicine. I am your run, bye. I wouldn't do that. Take them very seriously and, re-stratify and get them the appropriate help. Excellent question. Okay. Some studies have suggested as many as 1/3 of patients placed on high-dose opioid pain medications for chronic non-cancer pain may develop a misuse disorder. True or false? Opioids work very well for acute and chronic pain.
So we're still waiting for an answer to pop up in the chat.
Okay. Someone be brave.
So I see, yep, we have lots of brave people here. So I see true.
Yeah. Okay. Good.
And then we have a question again. Do all persons have a bit of bipolar in them?
No. So bipolar disorder is a psychiatric disease, and I think it affects maybe about 5%, 3 to 5% of the population. Now, what is often confused with bipolar is something called borderline personality disorder, where people have fluctuations in moods, they get really upset real easy. If someone breaks up with them or their partner leaves them, they want to commit suicide. That's often confused with bipolar. But no, not all people have elements of bipolar.
Okay, thank you. And we have 3 truths.
Okay, so the answer actually is false. While opioids work very well in the short term for pain, they do not. The body gets used to the medication and it stops working until the dose is increased again. Eventually, people can end up on very high doses of medication relief or even worsening of their pain, what we talked about earlier, the opioid-induced hyperalgesia. Long-term opioid treatment usually reduces baseline pain by about 50 to 60%. True or false?
Okay, so why? So we have a false.
Okay. And you're right, it is false. At absolute best, in the long run, opioids can decrease pain levels by 20 to 30% over baseline. And for most people, it's more like 10 to 15%. Most people will still have 85 to 90% of their pain, even when taking pain pills. That's chronic pain, okay? It used to be thought that pain treatment was pretty much the same as opioid prescriptions, but we now know this is not the case. So believe your patients when they come and tell you, this medicine ain't working no more. It is true. It is not false. So when we prescribe opioids, we have to risk stratify our patient and make accommodations for that risk into a treatment plan. As clinicians, we should become proficient in performing and documenting a risk assessment. And it's so important to screen patients for vulnerabilities and risk. When we assess our patients to figure out, should they be on opioids or not? We look for the chronic pain. Where is it? What is the imaging studies? Have they been documented before? Assess the impact of pain on quality of life. How is this affecting you? You know, are you depressed because of it? Are you able to function? What is your family saying? Assess the risk of opioid misuse. That is very important. And we're going to get to that in a bit. And assess the ongoing pain 4As. When we say 4As, we mean analgesia. Is the medicine working? Activities of daily living. Are you able to do things you want to do? Are there any adverse side effects like severe constipation? Okay. And are there any aberrant drug taking behaviors, such as, man, I feel stressed of the day. I just want to take some tramadol and make me feel better. Or I have an argument with my spouse. I just need to take some tramadol in order to calm down. Or I gotta tell granny, give me some pain medicine because I out of mind. Okay, so that's aberrant drug taking behaviors. So important for all clinicians, you gotta know which patients are more at risk of, to screen an opioid assessment for patients with pain. So what you should know in terms of opioid therapy, we have tools that we can use before we start them on narcotics. All right, to put them in a risk the risk category of high risk, low risk, or intermediate risk for abusing these medicines. We even have tools to use during the opioid treatment, and that's called the CALM. Okay, we have tools we can use that has to do with different drugs. So there are lots of tools. I'm just going to give you an example of the ORT. My screen's frozen.
No, your slides are moving. Assessing risk of misuse. That's the slide that we're on.
Okay, but I've advanced it and it's not moving.
Okay. You could maybe go backward. Let me see, and I'll tell you if it moves.
Okay, I went backwards.
Okay, we're still on assessing risk of misuse.
Yeah, these computers sometimes they just don't work, right?
Yeah.
Okay. It's not moving forward. So what I'm going to do, I'm just gonna, you want me to just come out and come back in and see if I'll make it better?
You can try.
Okay.
Or you can refresh. I see we have someone saying maybe try and refresh the screen.
Yeah, I tried that.
Dr. Halliday, are you still with us?
Oh, bam, back. But see now, very good. So I see.
One thing you can try and do is just stop sharing and restart sharing.
Okay. Let's try that.
And select your screen rather than the PowerPoint. So it says screen.
Yeah.
Screen 1 or something under share.
Okay, so mine does not do that.
I didn't know if it did.
Yeah, let me try again.
But it would be, if your PowerPoint is open on your screen and you share the screen, it would just come up.
Yeah. Okay, what are you all seeing now?
For your lovely face.
I wish. Okay.
Okay, it's starting to come up again. And so we see
All
your
right,
whole
now we see your
screen
screen.
now.
Yeah, now you can open your PowerPoint.
Okay.
And the sun is shining on you. So it must be a good thing.
Maybe. Okay, so it's giving me more. So in the middle of my screen, I see.
We see it.
Big blank.
It's blank. Yeah, in the middle.
Yeah, there's a box in front of your screen. Is there a
Yeah.
box in front of your PowerPoint?
Unfortunately. Okay, just give me a second. Let me try to get rid of this box. Well, we can just go. We can just go on. Okay. So unfortunately, my stuff is frozen. But let's just go. And maybe
You can go on.
stuff.
If you know the presentation, we can just go on.
Yeah. Okay. Let's just go on. Okay. So the opioid risk tool. So this tool is what we use for putting people in different risk categories depending on their likelihood to abuse opioids. And what we look at things as, what gender are you? Have you ever been abused if you're a female, have you been abused in childhood? Do you have comorbid major depression or serious mental illness? Is there a family history of drug use? Okay. And so once we have that, we put people in categories as mild, moderate, or severe, or severe in terms of their risk. And then we have monitoring. So in terms of what you all use for monitoring back in the Bahamas, how do you monitor your patients who are chronic opioids? Do you use contracts? Do you use urine drug screens? Do you look at their pharmacy list? What do you all do?
Maybe pharmacy lists, because I've had a pharmacist call me on a Sunday, said I prescribed some Petadine. I don't even work on Sundays. So I know it wasn't me. I think they just used a slip I had given before and wrote underneath of that slip their own Petadine. This was somebody who was had sickle cell disease, an adult.
Yeah. Okay. And we had that happening to us too. You would have patients who sometimes would go in the office and actually steal the prescription pad and write up their own medications. That's unfortunate. Okay. So what the recommendation in terms of best practices, if when you start a patient opioid therapy, baseline urine drug screen. You should also check with the pharmacies if possible to see if they're getting opioid medications from different people. Okay. The other thing you need is for them to sign a contract saying, hey, I have agreed I'll be on this medication. I won't ask other doctors for the medication. I'm not going to escalate therapy on my own. And I agree not to sell or give away my medications. Now, in a court of law, I can't do much, but at least with a patient, it emphasizes with them how important it is for them to actually stick to the contract and how serious the opioid is. So when you have your patients with that, you've done your baseline assessment. It is very important next to figure out, is this medication working? Okay. So for example, we had that gentleman who had the vascular necrosis, and he's asking for more pain medications. And the answer in that case was increase his therapy. When we increase opioids, what we should do is tell them we're increasing the trial basis. We're going to assess you to see if this is working or not. If it does not work, we're going to actually taper you down. And that is incredibly important to tell that to your patient, because otherwise they thinking it should go up and up over time. Okay, what we should also know in terms of opioid therapy is the morphine equivalence. What's been recommended in terms of doses is that you shouldn't go higher than 100 to 120 morphine equivalents for a patient, okay? Because any dose higher than that is not effective, it's not doing anything, all right? And finally, when we have our patients, it is so important to screen for mental illnesses, because people who have chronic pain, 50 to 60% have comorbid depression, anxiety, panic attacks, and even some substance use disorders. And it's important to address those, because if you don't address those, then their pain is not going to be controlled. There is going to be misuse, and you're going to feel frustrated as a provider because you feel like you're not getting anywhere with them. All right. I have a question to the audience. How easy is it to wean someone down of their pain medications? What have you all found?
So I'm still waiting to see if anybody puts an answer in the chat. But I will say it really isn't that easy, especially if they've been on it for a very long time and they convince you they needed to sleep or to function, that type of thing.
Yeah, it is incredibly difficult because patients who have been on chronic opioids, they are almost married to that medication. And for those who go through the withdrawal and the tolerance, their bodies feel horrible. So withdrawal from opioids feels like sickle cell crisis. Okay, a lot of people don't understand that because in the books they tell you, feel like the flu. It does not feel like the flu. It feels like someone is crushing your bones. It feels like ischemia to your bones or ischemia to your heart. Think about it that way. People who are having severe heart attack, they would tell you that pain is incredibly intense. It's the same thing with opioid withdrawal. Okay, the pain is throughout their bodies and it's incredibly intense. Okay, so do you all—
So before you go on, Dr. Bowe, we have decreased the dosage in increments because it's not easy. And then another question, what percentage of these patients with chronic pain are destructing and practicing cutting?
Okay, so you practicing cutting, you mean self-injurious behavior, right?
Yes.
Okay, in terms of randomized controlled trials, there is no way of knowing because we don't know. What we do know, though, is that patients with borderline personality and those with chronic pain, they do indulge in self-injurious behavior. The percentage of borderline personality in our in the American population, I think 6 or 7%. I don't know what it is in the Bahamian population, but I imagine it'll be a very, very small percentage of persons with chronic pain disorder or cutting. That is a different diagnosis. That's borderline personality with self-injurious behavior, and that person needs help. They need dialectical behavioral therapy. And we can call our trusty friends at Sanolins and get some psychologists involved with them if they're doing that. Okay. Let me ask you all a question. When we go and decrease our opioids, what is the recommended way of decreasing opioids per month? Anyone knows? Okay, so the recommendation is to go down 10% per month. So when I have my persons on like say chronic oxycodone and they've been on it for years, I can actually take about a year to get them off, because what you don't want is to call us and go to withdrawal and go back to the higher use. So for example, if my patient is getting 60 pills a month, what I would do is take them down by 6 pills every month until they're off. Does that make sense? So when you wean your patients, it's 10% per month and you go slow, and they will argue with you and try to get more medications. What we're gonna do is to try to support that patient more, okay? It's important for us to support them. Okay. So the last thing I want to talk about today is about what we do for our patients who we do think does have a disorder. They are addicted to their opioid medications. In the Bahamas, what do we have in terms of medication-assisted treatment for opiate use disorder? Is there anything? No? Okay, so
I'm waiting to see if anything pops up in the chat, and I haven't seen anything pop up in the chat.
Okay, in the US, and this is what I do in part of my psychiatric part, we have these medicines. We have methadone, we have Vivitrol, naltrexone, IM naltrexone, and we have this medicine called buprenorphine. And what we do when we find our clients with chronic pain, as well as who are addicted to their medications, we take them off of their opioid medications and give them one of those medications instead. And it's been found to be incredibly effective in terms of decreasing ER visits, in terms of hepatitis C, HIV, because a lot of our clients do inject like heroin if they can't get pills. We also give naltrexone IM. That's the IM version, and it's an antagonist to the mu receptor. So patients who are chronic pain, a lot of them don't like that so much because it means they cannot get an opioid as long as that's in their system. But again, incredibly effective. And patients like my colleagues who are physicians and the teachers and lawyers and so forth who are not eligible or don't want to be on buprenorphine, they're on Vivitrol, also called naltrexone IM. All right. And I have this one more thing to say before I open it up to more questions. It is so important to not label your patient as an addict if they're not, if they're just a treatment non-responder or someone with uncontrolled pain. because you will have a majority of your patients who stop responding to opioids, okay? And then at that point, what we need to do is start on alternative complementary medicines. So you try your SNRIs, you treat their underlying mental illness, try acupuncture, try yoga if it's available, okay? Sometimes it is, most of the time in our community it's not, right, in the Bahamas, but some people can have access to it. What's incredibly helpful is actually water aerobics. Go to the beach and walk up and down in the water, walk in the sand. So we have to become very skilled at alternative methods for chronic pain, because what the research has said is that chronic opioid therapy is not effective for the majority of people. What we want to do as clinicians is never abandon our patient. Sometimes it's incredibly frustrating having someone come to your office, always telling you, oh, I need more, I need more, I need more. And you're feeling like, oh my God, it's you again? But that's not our attitude, right? We're supposed to take care of our patients. So what we do, acknowledge the stress we feel, talk about it with a colleague, all right? I am very fortunate. I have my best friend's a psychiatrist. If I feel frustrated, I can just sit in their office and be like, y'all give me a session, okay? But it's important to manage our stress and acknowledge it surrounding these patients. Then we want to be compassionate towards our patient. They living in pain, they suffering, and they looking to you for help. A simple, hey, I hear you, I feel you, I have to bring on your medicines, I'm going to offer you something else. Let them know that there is help, okay? Let them know that you're not going to abandon them and that you're going to be with them in that journey. So thank you all for the talk. I am so sorry the PowerPoint cut off. I'm not sure what happened, but Dr. Black will have all the copy of the slides, and feel free to use them, distribute them. Feel free to shoot me an email or any questions you might have. And I just want to open up to the floor for any questions for me.
Thank you very much, Dr. Bowe. And while we wait for some of the questions to pop up, I'll just read some of the comments, that are in the chat. So we had a comment much earlier on that alcohol and marijuana dependence is a problem in the Bahamas.
Mm-hmm.
In terms of the medications that you mentioned for addiction, a lot of them are not available here.
That's right.
And it was the feeling that many of our addicted patients, or many of these drugs are actually on the streets.
Mm-hmm.
I'm not too sure about that. Our emergency department has patients who routinely come in for pain to get prescriptions. We don't refill prescriptions, but a lot of them do not seem willing to go anywhere else for routine follow-up.
Yeah.
We suspect dependence in some of our patients, but it feels as if our hands are tied and we simply have to give them a prescription.
Mm-hmm. Okay. Go ahead.
No, go ahead. You can answer, and then I'll read some
Okay.
more of the comments.
So yes, I totally agree with you all, especially the part of feeling that your hands are tied. So what we have done at our institute is actually develop protocols on how to address our clients when they come in this way. Because in the past, when you come to the ER, they just give you the pain medicine, you leave, right? But now we're recognizing this has created a problem. People are selling their prescription, people are taking their pills and giving to other people, people are injecting snorting their pills. So what we do, if you come to, let's say example, you come into PMH, if you all were able to develop a protocol with the ER saying, if this is a chronic pain patient, you do not give them the pain medication, or you give them 2 days worth of medication, document and say that you can't get any more, and have them follow up with their primary care provider or whoever gives them the opioid medications. They need to go through a tool, a management plan, and how they're going to manage the pain. Because if they're coming to the ER frequently for pain medications, that's an indication that the medicine is no longer working, and it doesn't make sense to keep going up and keep going up. You need to taper off. Okay. And so for some people who actually taper off and go on a drug holiday, it improves after a while and they can go back on opioids, but everyone is different. All right. In terms of marijuana use, yes, it's a big deal in the Bahamas. So far, there's no medication-assisted treatment for marijuana use. Off-label things I've used are things like mirtazapine, Remeron, because it brings down cravings. Also, topiramate, Topamax, it brings down cravings. Also, Neurontin, also called gabapentin, it brings down cravings. You can use those on a 3 to 6 month basis. It's effective for some people, not effective in others. For alcohol, however, I think we do have in the Bahamas, I think we do have medicines for it. Correct me if I'm wrong. I mean, we did as when I was an intern. There is Antabuse, disulfiram. Then you have Vivitrol, also called naltrexone IM or oral. We have a Acamprosate, we have topiramate, we have gabapentin. So those are things we can also use for alcohol use disorder. And you know what? Most people go to their primary doctors. They don't go to psychiatrists for these issues. So us as internists, we have to be very skilled at managing this. I mean, in fact, OBGYNs probably sees more addiction issues than primary care because women trust their OB provider. Yes, I'm able to do telemedicine consults. Hey, Devon.
Right. So if you're able to do telemed consults, can you tell us a little bit about how we may be able to access you for telemed?
Okay, yeah. So what I would have to do is talk to my chair, pick a day when we're able to do that. And then from my end, we just talk. So when you do that, you want for physician consults or would you prefer patient consults?
Dr. Curling, would you like to answer that question? What kind of, I think probably we're looking for a little bit of both.
Okay.
So it might probably be best for them to contact you one-on-one and then you figure it out from there through your email.
Yeah. So no problem with that. I think so Dr. Black has my information and we can go from there. But yeah, you feel free to curbside me, send me email, get my number, just ask, especially when it comes to physician consults. Because we do this all the time. We have this big group over here called ECHO. And what we do is we meet every 2 weeks on a Monday afternoon, and we just talk about our challenging patients and give each other's advice and support and different ways to manage it. That'd be awesome to set up for the Bahamas. I would love that.
Okay, so what I will do is I will share your contacts on the websites that I usually use to share the information about meetings.
Okay.
And so we have lots of congratulations on an excellent talk.
Thank you.
One
And
thing,
Dr.
Dr. Omala,
Go ahead.
I want to say
Go ahead.
Dr. Bowe, excellent presentation, and I have a question for you. Do you deal with babies whose mother were addicted to any of these drugs, and how do you deal with them?
Okay, the baby or the child. So in terms of babies, no, because they have our pediatricians do that directly. So if someone comes in an opioid use disorder, they're in withdrawal. For the baby, we recommend a tincture of opium or some methadone and weighing the baby down. That's how that's done. In terms of my psych clinic, yeah, because a lot of the kids have behavioral issues, especially marijuana, alcohol, and opioids. They have problems concentrating, focusing. They have temper tantrums. They have like defiant behaviors. And so in my psychiatric clinic, I work with residents and we see and supervise managing those patients. Did that answer the question?
Yes, it did. In my experience, when I was in Michigan, we had a lot of children on what I call a pharmaceutical list of drugs.
Yeah.
And I never thought about that they were in pain. I just continued to write those prescriptions that were written by former persons, residents who was passed down to me. That is so sad.
Yeah.
Thank you.
Thank you. And so, Dr. Bowe, we have from Dr. Moxie, excellent presentation. Can you provide a recap presentation of your algorithm for non-responders to opioids?
Oh, yeah. Okay. So you've tried them on the opioid medication. You've titrated up to 100 to 120 morphine equivalents a day. They are not working. So what you're going to do is have a conversation with your patient. Make sure to screen for depression, anxiety, panic attacks. Educate them on withdrawal and what they're going through physically as you wean them off. When you wean them off, you go down by 10% a month. So if they're on 90 pills, take away 9 pills. The next month, I can't do math. I think you're on the 83, take 10% from that. And that's the way you wean that down. A lot of times it takes 6 months to a year, okay, to actually wean a patient down. Then you try your alternative methods for pain. You've already done your Nsaids, you've already done your Tylenol. Think about your acupuncture, massage therapy, water therapy. Also, you can get your anesthetist on board, all right? Because sometimes they can do, if it's they can do blocks, they can do steroid injections, right? You can have your lidocaine injections as well. So pretty much that's how I wean people off and put them on alternative medications. They won't like it, but you know what they're getting was not helping anyway. And so you just partner with them and emotionally support them. And then when you get frustrated, you talk to your colleague. Let them calm you down too.
Thank you. And so we did have a question earlier. You may have already answered it. How do you help patients who are addicted and maybe in denial?
Oh, okay. So we use motivational interviewing. Whenever you have a patient who's addicted to something, it is very important to get on their page, not try to get them on your page. And so you kind of just present the information. So if I have someone who's addicted to pain medication and not use it properly and use it for stress, I just give them information. Did you know that people who are on this medication, 30% of them will have trouble not using or getting off? Did you know these are signs of addiction? Your mommy mad at you, your daddy mad at you, you aren't showing up to work, you're driving, drinking and using these medications. Those are all signs of addiction behavior. Did you know that? And they go, I don't know, I had nothing to do with me, but you give the information and you assess their readiness to change. Some people are in that stage of change called pre-contemplative. No matter what you tell them, they can tell you they don't have a problem. But the good news is research has shown that even you just bringing it up a year from now, their behaviors would have decreased, okay? So sometimes you feel like you're talking to a wall, you're not. What you're saying is very effective because patients do go home and think. And about a year later, something in their behavior would have changed. We are never fighting a losing battle. We are winning this battle.
Thank you. And we have lots of congratulations, excellent presentation. Thank you for a phenomenal presentation. And we have a question from Dr. King-Strawn. How do you feel about using Nsaids with paracetamol as an alternative? Have you found that combination to be effective when there is non-response from opioids?
Okay, so in the US, we don't use too much paracetamol, right? But the studies in Europe have shown that it's incredibly effective using paracetamol and alternating with Nsaids. So here we use acetaminophen and Nsaids, but over in Europe, that's what they use, and it definitely works, especially the IV formulation of the paracetamol.
Great. Thank you. I do not see any questions that we have missed in the chat, Dr. Bowe. So do you have any final closing comments for us?
Yeah, what I want to say is when you work with patients with chronic pain, it can be very stressful for the patient, but also as you as a provider. And it's easy to get burned out. It's easy to get frustrated, especially what's going on in our community with COVID and so forth, right? I want to tell you as clinicians, we need to look out for compassion fatigue. When you find yourself mad going to work, upset, and when you find yourself sucking your teeth, and I don't want to see these people, you're probably burned out because doctors love taking care of people. This is why we came into the profession. But if you find yourself with compassion fatigue, get help, take a break, talk to a colleague, because if you are feeling frustrated, you're not going to be any good to your patient. Okay, but keep up the good work, all right? And let's support each other, especially we've lost so many colleagues. You know, it's devastating. So just keep up the good work and work as a team. And thank you for your time. And Dr. Black, thank you for that amazing introduction. I was like, oh, that is. So thank you.
Thank you very much for agreeing to speak with us, Dr. Bowe. It was very nice to read your CV and see all the amazing things that you've done. And thank you for sharing with us. And thank you to you, our audience, most importantly, for participating. And again, remember to take advantage of Ms. Ferguson's presentation on non-communicable diseases. Remember, you can get CMEs that count towards your Bahamas Medical Council accreditation. There are 3 CMEs for at least each module. So I will send that information out again, so people have the information to get that app and use the module for CMEs that are free. Please join us on Wednesday, the 13th of October. That's when our next presentation will be, and we will send out a notice for that meeting shortly. And again, please be safe. We think about our colleagues that we have lost, our countrymen, and we pray that we get through this soon, as much as I don't believe that soon, but we still want to hope for soon. And everyone be safe. Thank you and have a great day. And we will share the slides.
Thank you.